Good evening or afternoon to our esteemed speakers, ladies and gentlemen. I'm Dr. Tan Sok Siam, hepatologist working in Malaysia. First of all, thank you, Jeffron, for inviting me to moderate and speak at this second webinar on Liver Support Alive. The theme of today's webinar is on the role of DPMAS in clinical practice. We have here today 3 distinguished speakers to address this and share their vast experience in managing liver failure patients and in managing DPMAS. I would like to briefly introduce our 3 speakers. And first of all, I'd like to introduce Professor Zhao Li. Professor Zhao Li is the Chief Physician of Artificial Liver Center, Beijing, Yao'an Hospital, Capital Medical University. She's involved in the study of adenovirus-mediated CCR5, CXCR4 antisense RNA against HIV-1 and anti-HIV research targeting CCR5, CXCR4 co-receptors. She published vastly in more than 20 papers, 6 of which has been included in the science and engineering papers. Then we will have our second speaker. Our second speaker is Associate Professor Ranista Ratanarat. She's the head of Critical Care Division, Department of Medicine, Sirinaj Hospital, Mahidol, University, Bangkok, Thailand. She's a member of the Nephrology Society of Thailand and a member of the Royal College of Physicians of Thailand. And then last but not least, we have our third speaker, Dr. Sandip Satsangi. Dr. Sandip is the lead consultant hepatologist and liver transplant physician of Apollo Comprehensive Liver Care, HVB Surgery and Multi-Organ Transplant, Apollo Hospital, Bangalore, India. He scored top marks in his universities and also in his postgraduate, and he's published more than 20 several publications and book chapters. He has also served as the assistant editor of the Journal of Clinical and Experimental Hepatology, which is the official journal of the Indian National Association of Study of the Liver. This evening, our agenda would be, I will give you a brief introductions before our 3 esteemed speakers talk about DPMAS and PE. Professor Zhao Li will talk about DPMAS and plasma exchange for ACLF. Associate Professor Ranista Ratanarat will talk about the combinations of DPMAS and other ECBP for liver failure. Dr. Sandip Satsangi will be talking about DPMAS in liver failure, his clinical experience. After that, we will have question and answer and discussion. And at the end, I will ask for summary from each individual speaker on the tips from their talks. So before I start, some housekeeping. The host has muted our audio, so in order to ask any question, please type in the Q&A button at the bottom of your screen. And I would like to remind the speakers that we keep to the allocated 20 minutes. So I would like to start with a brief introduction. We actually have a spectrum of liver failures. The liver responses to acute hepatic insult varies according to the underlying hepatic condition. If we start off with a normal liver and have an acute insult, we will have acute liver failure. If the patient has chronic liver disease or compensated cirrhosis, and we have an acute insult, we end up with liver failure, what we call acute on chronic liver failure. And usually these patients have jaundice that progress to ascites or hepatic encephalopathy. Patients with compensated cirrhosis sometimes can get an acute insult and decompensate with GI bleed, hepatic encephalopathy, ascites, hepatorenal syndrome, sepsis, or combination of these. Whereas patients with decompensated cirrhosis after an acute insult would develop further worsening of decompensated cirrhosis with sepsis, bleeding, or acute kidney injury. First of all, acute liver failure, we all know, is a medical emergency. Luckily, it's rare, 10 cases per million persons per year, but this has been described since the 1970s. This is what acute liver failure looks like. Patients tend to present with a high INR, more than equal 1.5, and any degree of mental alterations, what we call encephalopathy, and this usually occurs in a patient without pre-existing cirrhosis and with an illness of 26 weeks duration. There are many subclassifications of acute liver failure, but more importantly, patients have encephalopathy after an episode of jaundice. And this could be divided into hyperacute when it happens in 1 week, acute, subacute. Another group will call it as fulminant or subfulminant, or even another group, the Japanese consensus, called it acute, subacute, and fulminant or late onset. This slide shows the adult registry of acute liver failure from US 1998 to 2019 with more than 2,600 patients. Basically, we can see that with the availability of liver transplantation for acute liver failure, there is a decrease in the overall mortality. In the past, it used to be 80% mortality, now it's about 33% on the average. But certain etiology, like drug-induced liver injury or hepatitis B, the overall survival is still poor at 53% compared to very good overall survival for paracetamol toxicity and hepatitis A, and also pregnancy. Acute and chronic liver failure is first described in 1995. And this liver failure, it occurs in patients with existing chronic liver disease, which can be cirrhotic or non-cirrhotic according to the APASO guideline, and due to an acute insult, which is also called a precipitant. And this, for example, can occur in a chronic hepatitis B patient with acute dengue hepatitis, or in a patient with alcoholic liver disease with acute alcoholic hepatitis. The prevalence here is higher compared to acute liver failure. It was reported at 24 to 40% patients with cirrhosis admitted to hospital. They have high short-term mortality at 33 to 51% at 28 to 90 days. However, reversal and recovery is possible. There are various definitions for acute and chronic liver failure. There is the APASO, the ECLF, and an SCLD. The APASO criteria defines it has to be an acute hepatic insult manifesting with jaundice and coagulopathy, and within this time, in 4 weeks, the patient will manifest with clinical evidence of ascites and or encephalopathy, and the patients could have diagnosed or undiagnosed chronic liver disease, and this is associated with high mortality. So patient could have compensated cirrhosis, which can be diagnosed or undiagnosed, or the patient could have just have chronic liver disease but no cirrhosis. And in the APASO guideline, ACLF main organ failure is liver is the primary problem to start off with others subsequently. According to the European or CLIF consortium, ACLF is defined as an acute deterioration of pre-existing chronic liver disease, usually related to a precipitating event and associated with increased mortality at 3 months due to multi-system organ failure. This group thinks that it has to have liver cirrhosis only, but the patient could be compensated or decompensated cirrhosis, and liver failure is mandatory. And the organ failure here systemic inflammation leading to kidney failure as the primary problem. In the NASC-LLD, the syndrome is characterized with acute deterioration in a patient with cirrhosis due to infection presenting with 2 or more extrahepatic organ failure. And again, this group thinks it's only had the cirrhosis patient, and the patients could be compensated or decompensated, and there are 2 extrahepatic organ failure. And again, systemic inflammation leading to extrahepatic organ failure is important organ failure criteria. So when the liver fails, there's accumulations of metabolites, pro-inflammatory mediators, and toxins like ammonia, bilirubin, bile acids, nitrogen-containing molecules, DAMs, pro-inflammatory mediators, and soluble B7, which is important in terms of increasing the risk of sepsis. Because of this, if we have the rationale for the liver support system is to remove toxin to prevent further aggravation of liver failure. Hopefully, we can modulate the immune responses, support hepatic functions, provide an environment to stimulate liver regenerations, or bridge to liver transplantation. So thank you very much for your attention. It is my honor to invite our first speaker, Professor Zhao Li. She will address the topic of DPMAS and plasma exchange for acute and chronic liver failure. Over to you, Professor Li.
Okay, thanks for Professor Tan's introduction. And today, my topic is DPMAS+PE for ACLF. And I come from Beijing Youan Hospital, Capital Medical University in Beijing. As we all know, liver function is very complicated, including metabolization, immunology, detoxification, synthesis, etc. And in Chinese guideline for the liver failure, the definition of liver failure is the inability of the liver to perform its normal synthetic and metabolic function as part of normal physiology. There are 4 kinds of liver failure: acute, subacute, acute on chronic, and chronic. Today, we are focused on the ACLF, acute on chronic liver failure. Liver failure leads to function decline of liver synthesis, metabolization, and detoxification. This function decline accompanied with accumulation of toxins result in complications such as cerebral dysfunction, circulatory dysfunction, renal dysfunction, immune dysfunction, etc. And the complications react on liver function, aggravate liver dysfunction. So it's a vicious circle. Early and efficient treatment is always necessary for liver failure patients. Here are the main toxins and complications. For liver failure, the treatment includes three parts. First one, medicine management. It's a basis which is very, very important. Liver transplantation as the last method for liver failure patients faces donor shortage and high cost. On the base of medicine management, artificial liver support system, which is called ALSS, could help some patients to survive without liver transplantation. For the other patients, ALSS could be a useful bridge to LT. ALSS is an extracorporeal support system which can temporarily replace partial liver function. It has different types like PDF, HDF, PE, plasma exchange, and plasma blood adsorption, and some other types. ALSS is an in the ALSS there are one method called DPMAS. In plasma absorption, DPMAS is a short of double plasma molecular absorption system. It was listed in the Chinese guidelines for liver failure. As written, DPMAS can not only absorb bilirubin but also remove some inflammatory factors. Besides, there is no loss of plasma. So what is DPMAS? What is principle? Well, as we showed, DPMAS is a combination of HA3302 and BS330 in the plasma absorption mode. HA3302 and BS330 are the two different hemoperfusion cartridges. The BS330 could absorb bilirubin and bile acid specifically, and the HA330 could remove the middle two large molecular toxins due to liver dysfunction, including inflammatory mediators, ammonia, phenols, etc. Based on the principle, DPMAS could be applied for patients with complications such as hepatic encephalopathy, used as pre- and post-liver transplantation to provide a stable in vivo environment. Besides, it could be conducted for patients with hepatitis and relieve the jaundice, which is a very common clinical symptom. Well, as we have a basic introduction of DPMAS, next let's see how about its effect on liver failure patients. This is a study. It's a prospective study. They compared the plasma exchange PE with DPMAS for HBV-related ACLF patients. This is a single-center prospective controlled pilot study. It enrolled altogether 70 patients with ACLF, and the patients were divided into two groups. The first group is TPE group. In this group, patients received the standard medical therapy and therapeutic plasma exchange, that is TPE. And the frequency is 2 to 3 times per week, and each time 2 to 3 hours per session. And the plasma rate is 20 to 30 milliliter per minute. And in the DPMAS group, the patient received standard medical therapy and DPMAS, also 2 to 3 times per week, 2 to 3 hours per session. The total blood flow rate is 100 to 150 milliliter per minute, and the plasma rate is 25 to 50 milliliter per minute. And the follow-up period is 12 weeks. And let's see the results. No matter PE or DPMAS group, the ALS therapy could effectively reduce the inflammatory mediators level and bilirubin and bile acid level. Meanwhile, they found that patients with DPMAS had less loss of albumin when compared with PE group. And the survival rates of DPMAS and TPE have no difference. DPMAS had less adverse events. We can see in the DPMAS group, no allergy or shock, and less nausea, less bleeding in the puncture site, less clotting-induced treatment interrupted. So here is the study conclusion. DPMAS and TPE were both effective and safe for HBV ACLF patients treated by entecavir. Despite TPE resulted in higher removal rates of bilirubin and CRP, it has disadvantages as follows: requirement of large volume of fresh frozen plasma, risk of plasma allergies, blood-borne disease transmission, higher loss rate of albumin than DPMAS. The pro of PE is to eliminate toxins with protein and clotting factor supplements, but it still has many cons, just like the risk of cross-infection, shortage of plasma sources, varying degrees of allergy, citric toxicity, obviously dose-effect relationship, and secondary water sodium retention. And for DPMAS, it has no protein and clotting factor supplements, but it has many pros, just like no risk of cross-infection, no plasma, less allergy, no citrate toxicity, no water sodium retention, and double dose treatment. Sometimes you could do double dose if you want, if the patient has extremely high level of bilirubin. So we could use a hybrid treatment mode, just like DPMAS plus PE. This is another study about hybrid treatment, a single center experience of non-bioartificial liver support system among Chinese patients with liver failure. And this design is a single center retrospective control study. The patients were divided into MBALS group and non-MBAL group. The purpose is to investigate the status of MBALS and their effectiveness in improving survival in liver failure patients. We can see in this study there are different types of ALSs, including hybrid treatment like PE plus PP. Here is a result. The patients in MBALS group had higher 48-week survival rate. For ACLF patients, the 48-week survival rate of MBAL group was higher than non-MBAL group in the mild score less than or equal to 30 subgroups. So here is the conclusion. MBAL treatment improved the survival of patients with ALF, SALF, or ACLF, and the reasonable combination of purification technologies maximize the advantages and minimizes the disadvantages of each approach. And last one, lower MELD score less than or equal to 30 were associated with improved outcomes relative to higher MELD scores. And here is our own study. It was conducted in my hospital, and it's a retrospective controlled study. Patients were divided into two groups, PE group or DPMAS plus PE group. In PE group, PE with fresh frozen plasma, about 2 liters were given to the patients. And the treatment duration was 2 hours. In DPMAS plus PE group, we did DPMAS first and then followed by PE with fresh frozen plasma, about 1 liter. So it's a half dose PE. And the treatment duration was 3 to 4 hours. The outcome was organ function and 28 days liver transplant-free survival rates. This figure shows that the total bilirubin levels immediately after treatment and at 24 and 72 hours after the treatment were markedly decreased in DPMAS plus PE group than that in PE alone group. Figure A shows that for all patients, the 28-day survival rates was not statistically different between PE and DPMAS plus PE groups. They were 62.3% and 72.2% respectively. And figure B and figure C shows that the 28-day survival rates in DPMAS PE plus PE group were statistically higher than the in PE group. They were 57.4% versus 41.7%. And this difference was seen in the intermediate advanced stage patients. So this is our conclusion. Compared with PE treatment alone, DPMAS plus PE might improve the liver function and reduce the rebound of bilirubin in patients with ACLF. DPMAS plus PE might improve the 28 days liver transplantation-free survival rates for HBV ACLF patients in intermediate advanced stage. DPMAS+PE may be an available ALSS-approached treatment for HBV-related ACLF. Of course, further prospective studies are needed to investigate the effect of DPMAS+PE on long-term survival. And we could also see that if we choose the mode of DPMAS+PE, just like in this study, we need less volume of plasma. We don't need two liters of plasma anymore. We just need 1 liter of plasma per treatment. So in brief, DPMAS+PE is very useful to treat ACLF, and we need further prospective studies to investigate its effect. Thank you for listening, and this is our team.
Thank you very much, Professor Lee. It's an excellent overview and a very informative talk. Now it's my privilege to invite our second speaker. Our second speaker is Dr. Ranista Ratanarat. She will share her insight on combination of DPMAS and other ECBP for liver failure or in critically ill patients. I'm sorry. So over to you, Professor.
Thank you very much, Professor Tan. Here is my talk. Is the combination of DPMAS and other extracorporeal bacterification in critically ill patients or in liver failure patients. As a previous speaker already mentioned regarding type of liver failure and role of extracorporeal bacterifications or artificial liver support treatment for like bridging therapy before transplantations. But all of us already know that the limitations of liver transplantation is due to organ shortage, patient instabilities, or some case with secondary liver failure in the setting of multi-organ dysfunction syndrome. And goal of extracorporeal extracorporeal liver support system is to expedite recovery from acute decompensation in ACLF, to avoid premature and unnecessary transplantation in ALF patients with the potential for liver regeneration and spontaneous recovery, for example, acetaminophen overdose, and to serve as a bridge to liver transplantations. However, because of intensivist, so for intensivist point of view, the goal of extracorporeal liver support device include to treat hepatic encephalopathies and hepatic cerebral edema, intracranial hypertension, to restore and maintain hemodynamics, because most deaths in acute liver failure and ACLF are attributable to distributive shock, to prevent end organ damage, especially other organs like kidney, lung, hemodynamic, and to be bridging therapies. On the basis of artificial liver support system, we aim to remove not only albumin-bound toxin, but also water-soluble toxins, and to eliminate cytokines and modulate the inflammatory response involved in liver failures. Here are the examples of toxin that we already mentioned. Other than these, it includes many pro and anti-inflammatory mediators. Unfortunately, here I show the 4 randomized control trials in extracorporeal liver support treatment. FUMA trial, they use MAS in acute liver failures. Helios trial, they perform Prometheus in ACLF. Relief trial perform MAS in ACLF. All of these trials show no benefit in terms of survival. However, only one study which Professor Larson conduct, it showed that high volume plasma exchange show beneficial effect in terms of mortalities or survival to hospital discharge. Here is full MAS trial in use MAS in acute liver failure, no significant 6-month survival. Relief trial MAS in ACLF, again, no benefit in survival. Helios trial of using Prometheus compared to standard medical treatment in ACLF. For the therapeutic plasma exchange, we try to remove abnormal circulatory factors, including antibody, circulatory immune complex, and other toxins like albumin-bound toxins, and replace with specific plasma factors or FFP. The data published in Journal of Hepatology show that high volume plasma exchange using FFP X to 12 liters is so high. Compared to standard medical treatment, can improve overall survival to hospital discharge significantly. However, in the group that can be performed with liver transplantation, high volume plasma exchange provide no difference in survival. The problem of this is come from shortage of organ damage. Here is, as I already showed, that in patients who were transplanted, high volume plasma exchange did not improve survival. Even systemic review show beneficial effect of extracorporeal of artificial liver support in terms of hepatic encephalopathy, mortalities, and no some serious adverse effect. But the guideline like now show that for acute liver failure, ESO show that suggest that only plasma exchange in randomized control trial can be improved transplant-free survival. And also for APASL 2019 suggests that we might use plasma exchange to be like a bridging therapy in case with ACLF before liver transplantations. And they also suggest that the combination of plasma exchange with therapy to potentiate liver regeneration should be evaluated in patients with ACLF. The explanation for disappointing clinical outcome, especially for randomized control trial in liver support, maybe come from the number of patients. Maybe we need the larger randomized control trial. For population related, we might need to identify specific outcomes in different populations. For example, in ALF, most of treatment, liver support treatment used for bridging to transplantation, then no difference in transplant-free survival. In ACLF, the benefit of this case show only in moderate to high risk group, for example, for CRIP score higher than 2. The disappointment may come from intervention related. For example, for the timing of the liver support treatment or some mechanism of toxic substance removal. In high volume plasma exchange, in the literature show they have to use as much as FFP higher, for example, 9 liters per session. So the problem found with the shortage of FFP adverse effect. For the mechanism of toxic removal, if you need to remove the cytokine and moderate inflammatory response involved in liver failure, maybe DPMAS gonna be good choice because they not only remove the bilirubin but also remove inflammatory mediators like Professor Lee already mentions. Here is the conclusion of study with clinical endpoint using DPMAS. You can see that if you use DPMAS combined with partial plasma exchange, it's gonna be better in terms of survival, especially in intermediate to advanced stage patient, as Professor Lee already mentioned. Here is the data we already seen in the last speaker. So if in my case or in my institution, if we found the case with moderate to severe liver failure according to the grading system, we use DPMAS combined with plasma exchange, not only plasma exchange alone. Other reason for artificial liver support which might not so good in terms of study, maybe because of the water-soluble toxin, for example, ammonia. For DPMAS, in my point, I saw that after DPMAS plus therapeutic plasma exchange for 2 hours and 2 hours, concurrently 2 hours of DPMAS and 2 hours of plasma exchange, they did not show the effectiveness for removal ammonia. And if we look back to the history of retrospective study in China, you can see that they conduct plasma exchange combined with hemoperfusion with HAT32 and CRRT in many studies. And these studies show improvement in hemodynamics and oxygenation. It means maybe the use of other extracorporeal blood purification maybe provide better in terms of hemodynamic, volume control, and so on in the critically ill patient. For hyperammonemia in liver failure, we all know that they cause alteration in neurotransmitter synthesis, release, increase oxidative stress, and so on. For the net effect, they induce astrocyte swelling, vasogenic edema, disruption in blood-brain barrier, and cerebral edema. However, ammonia has low molecular weight of only 17 Daltons and low protein binding capacity, water soluble. By this basis, it can be removed effectively by conventional RRT, especially in CRRT, which you can provide the treatment continuously over 24 hours per day. Here is for the CRRT, they can provide the clearance of ammonia effectively. This data published in Critical Care Medicine 2020 show that ammonia dynamic on day 1 to day 5 decreased gradually after treatment of CRRT, and proportion of patients with mature extreme hyperammonemia, like a higher than 150, decrease in the number of the patient with the extreme hyperammonemia after treatment with continuous CRRT. For this paper, they show that they start CRRT very early after ICU admissions. For example, only 4 days after admissions, and they use higher dose. For example, approximate 40 milliliters per kilogram per hour, higher than conventional CRRT that we use in critically ill patients, which is 25 to 30 milliliters per kilo per hour. And the mode of treatment cannot be CVVH-DF or CVVH. If we look back to the randomized control trial in extracorporeal blood purification, extracorporeal liver support therapy, for high volume plasma exchange, you can see that they show higher degree in terms of a better degree in terms of SOFA and TRIF cardiovascular score. It shows that this can remove cytokine effectively. For MAS study or relief study using MAS in ACLF, they show better in terms of hepatic encephalopathy. For the explanation that about the result, the plasma exchange use the very high volume of plasma exchange, so they can remove total or near total of toxic substance, including not only albumin bar but also water soluble toxin. For MAS system, the system include hemodialysis filter. It means they include renal support system into MAS system, and their treatment for longer duration, like 6 to 8 hours. This may be explained in the better of hepatic encephalopathy, because higher dose of CR of renal replacement therapy or higher dose of MAS treatment provide higher removal in terms of ammonia. For our institutions, we have we are the government hospital. Even we is the one of liver transplant center, but we have some problem with organ shortage. We have the limit number of ICU beds, so only severe case with other organ involvements other than liver can be admitted. But we have availability of CRRT machine. In fact, we provide the treatment not only with DPMAS, but also combine DPMAS with plasma exchange and CRRT during the period of this, like after liver failure, approximate 5 days to 1 week. We use the criteria like criteria for extracorporeal liver support in other study for start the treatment with acute liver failure and acute on chronic liver failure. For ACLF, we use the APACEL criteria with the AARC score in grade 2 or 3. We cannot use it in grade 1 because of the financial problem. So for us, the role of extracorporeal liver support we use in case only in case with liver transplantation, or in case that we hope that the patient gonna recover. For ACLS, we use extracorporeal support for recovery or for bridging to transplantation. Here is the model from APACEL consensus recommendation. We try to follow according to this guideline also. Here is the case. Here is our case in the last 2 years. You can see that our case show the diagnosis, almost a diagnosis is acute on chronic liver failure. 3 were acute liver failure case. But for the treatment, we combine the treatment not only DPMAS, but we use the DPMAS combined with therapeutic plasma exchange, like partial therapeutic plasma exchange, and almost all cases were treated with CRRT. Here is the case of us. Unfortunately, the outcome is not so good. We can send the patient to the transplant surgery room, only 2 cases, and they survive. But others, we start the treatment quite quite late because of the limitation of ICU space. Then almost all patients underwent the treatment. For the biochemistry, as you already know, the total bilirubin CRP decreased after treatment. But if we compare DPMAS alone with DPMAS with sequential plasma exchange, you can see that the PT of case with sequential plasma exchange decreased significantly. Then we always provide both treatment concurrently, I mean DPMAS and sequential plasma exchange in case with prolonged or coagulopathies. And if we compare DPMAS with versus without CRRT, you can see that if without CRRT, the ammonia level gonna increase. But if we conduct CRRT with the high volume CRRT, the ammonia level increase according to the time of treatment. Thank you very much for your attention.
Thank you, Professor Ranista. Thank you for an interesting and very informative talk. So this leads me to and he will share his experience on DPMAS in clinical practice. Over to you, Dr. Sandeep.
Thank you, Dr. Tan. Good evening, everyone. Please let me know if my screen is visible. Yeah, so we had very good, elegant talks telling us about the role of DPMAS in liver failure and how we can use it in our clinical practice. So I have been using DPMAS over the last 1 year or so. So as a disclosure, I would like to mention that this is not any guidelines which I'm trying to mention, but just where I'm trying to place this in my clinical practice. So though I have used it for a lot of cases, I'll be presenting 2 index cases, which will, so other cases are more or less revolving around these 2 cases. We have heard about these 2 cartridges, the hemoperfusion devices, that is HA3302 and the BS330. The first one is responsible for removal of hepatotoxins by adsorption technique, that is removal of mercaptans, ammonia, aromatic amino acids, phenols, and all the inflammatory mediators, whereas the BS330 removes the bilirubin and bile acid. So it basically combines both these modalities. So the case number 1, which I'm presenting, is a case of a young male, a 38-year-old male who presented to us with progressively increasing jaundice since about a month and started noticing abdominal distension since 20 days. He gave history of significant consumption of alcohol, approximately 200 grams per day, and he was abstinent since approximately the time he noticed jaundice. There were no complaints of any fever, but he does say that he was having pedal edema on and off over the last 1 year before presentation. On examination, he was grossly icteric. There was pedal edema bilateral. There was ascites, and there were no hepatic flaps. So these were the lab parameters which we noted. You can see that the TLC was marginally high, neutrophils of 70, platelets were low at 1.1 lakh. The total bilirubin was 42 milligram per deciliter with a direct component of 34. The AST and ALT was significant of suggestive of alcoholic hepatitis. The albumin was 2.8, the creatinine was 1.8 on presentation, sodium of 132, and the INR was 2.9. All the viral markers from A to E were negative, and on imaging, there was a cirrhotic liver, no portal vein thrombosis, and no space-occupying lesion. And there was ascites. So we had sent the sepsis workup at baseline. The procalcitonin was 0.15, and the blood, ascitic, and urine cultures were sent. Subsequently, 48 hours later, all of them turned negative. In the urine routine, we had 3 pustules. There were no protein, and the bile cast and pigments were present. In the ascitic fluid workup, he had a high SAG ascites with low protein, and there was no evidence of spontaneous bacterial peritonitis. So with this, we made a working diagnosis in our unit of acute and chronic liver failure, the acute component being severe alcoholic steatohepatitis, the chronic component being alcohol-related cirrhosis of liver. The acute kidney injury, we had certain differential diagnoses in our mind. One would be pre-renal, probably a volume responsive type, either a hepatorenal syndrome or a bile cast nephropathy. So this is what our diagnosis was. In the severity scorings, the MEL sodium was 38, the grade of ACLF was 2, and we had 2 organ failures, that is the liver and the coagulation. So this is how the patient presented to us. So we started giving him supportive therapy. At our center, we are not in favor of steroids. So usually I don't place the patient on steroids, though this was qualifying for severe alcoholic hepatitis because my experience with steroids is bad. Volume replacement with IV albumin was done as the creat was 1.8. So this was the index presentation. You can see the creatinine of 1.8. Subsequently, then the next day, the creatinine rose to 2.5, and obviously this now qualifies for a organ failure as per the canonic and EASL definition. So my patient from ACLF grade 2 on admission went on to ACLF grade 3. So now he had liver failure, he had coagulopathy, and he had kidney failure. So this was on 22nd January. And at this point of time, we started him on terlipressin infusion, and we wanted to maintain a MAP of approximately the mean arterial pressure of approximately 75 mmHg. Subsequently, the patient's urine output started declining to around 600 to 500 ml per day, and the need of living donor transplant was explained in detail to the patient's family. But however, because of the alcohol being the primary culprit, the family was not very keen for a living donor prospect at that point of time. The subsequent day on 23rd January, you can see the creatinine further rose to 2.7. The bilirubin, which was 42 on presentation, went to 44. So on 27th, on 23rd is the day he underwent the DPMAS with the BS330 and HA332. He tolerated the procedure well. He was shifted back from the ICU to the ward. And you can see the results over here. So this was on 23rd Jan where he underwent the DPMAS. The creatinine started to come down on the next day of the DPMAS from 2.7 to 2.4. The bilirubin from 44 came down to 31. The INR was more or less the same. The sodium was more or less the same. Immediately the next day, there was a rebound and the bilirubin started increasing from 31 to again 34. The creatinine, however, luckily started continuing the downward trend from 2.4 to 2.1. INR was more or less the same. On 26, again, there was a rebound of creatinine as well, and the bilirubin continued its rising trend from 34 to 36, and the creatinine from 2.1 to 2.2 milligram per deciliter. So at this point of time, on 26, he underwent the second session of DPMAS, again with BS330 and HA332. You can see on the subsequent day, the creatinine took a downward trend again to 1.4. All this while the terlipressin infusion was on and the albumin support was on. The creatinine continued downward trend. The bilirubin from 36 directly dropped down to 19.5. The INR was more or less on the same to 2.8 to 3. And on 28 Jan, the creatinine further came down to 1. The bilirubin from 19.5 again started increasing to 20. INR was 2.7. So he was discharged at this point because of a lot of financial constraints. Most of these patients don't have insurance cover, and obviously it will not be covered if they have alcohol as the primary etiology. But the point to mention was he presented to us with ACLF grade 2, in hospital had a worsening to ACLF grade 3. And on discharge, you can see again, he was meeting the criteria for ACLF grade 2. That is, he had a liver failure with a bilirubin of more than 12, that is 20, and the INR, which was 2.7, which is more than 2.5. So he was discharged on ACLF grade 2. Subsequently came back to us after 3 days. The creatinine further came down to 0.9, then had increased to 22. INR was 2.3. So the INR had significantly come down from 2.8 to 2.3. So here the patient turned from ACLF grade 2 to obviously no ACLF, and the organ failure was only 22. So as per the canonic definition, though he has one organ failure, we'll call this as no ACLF because the creatinine has come down to less than 1.5. So we had still explained them about the prospects, the need for a liver transplant. Unfortunately, there was no liver donor. There was nobody in the family who was wanting to donate for the patient, and also there were a lot of financial constraints. So patient subsequently went back to his native on 31st January, which is approximately 250 kilometers from our center. On Feb 15th, I get a call from the relatives that the patient is suffering from abdominal pain and fever. So we guided him to a local hospital wherein an evaluation was done, and he was found to have spontaneous bacterial peritonitis. In the subsequent 24 hours, I was in contact with the GP treating the patient. He developed hypotension and requiring escalating inotropic support. He was not able to get shifted to our center because of the poor hemodynamics. He started having worsening AKI. The creat had gone up to 3.2, metabolic acidosis, multi-organ failure, and this patient expired on Feb 17. 2 days after the presentation to that hospital, this patient could not get shifted at our center, and he passed away. So what are the learning points? This patient had a rapidly worsening liver failure and kidney failure while he presented to us in our index presentation. The etiology of AKI, in retrospect, I was thinking in terms of bile gush nephropathy, superimposed hepatorenal syndrome. Why I was thinking that? The reason is this. So there are certain predictors of response of terlipressin in hepatorenal syndrome. And the most important, the poor deterrent is going to be if your bilirubin is going to be more than 10. even if your patient has underlying HRS, the chance that he's going to respond to terlipressin is going to be lower if the bilirubin is going to be more. Second is going to be the grade of ACLF. If the grade of ACLF, as the grade of ACLF increases, your chance of responding to terlipressin is going to decline. So DPMAS basically helped my patient in improving his kidney functions, and liver functions at least stabilized. I would not say it improved, because it was more of a cosmetic benefit of bilirubin coming down and everything. But as you saw the chart, after the session of DPMAS, after the initial decline, the bilirubin again started to creep up. From ACLF grade 3, which was on day 2 of my presentation, of the patient's presentation, he went into a stage of no ACLF. This, I believe, was the golden window for the liver transplant for this patient. However, because of the lot of issues, this was not possible. The patient developed a subsequent septic hit and developed a repeat ACLF, and he could not be salvaged from this point of time. So from my point of view, obviously from this case, DPMAS was not a substitute for liver transplant, but it was like a bridge to transplant, wherein from grade 3 ACLF, I could get my patient to no ACLF stage, wherein if I could have transplanted him, I was quite certain I could have had a good outcome. This is the case too, which I have. This is a 42-year-old female who was diagnosed with autoimmune hepatitis related decompensated cirrhosis of liver. She was had other autoimmune problems like hypothyroidism, which was well controlled on thyroxine. These were her labs on her routine OPD follow-up. Her total counts always used to be in the range of 2,800 to 3,500. Platelets were low. She was having pancytopenia because of hypersplenism predominantly. Her bilirubin was around 11.4 with a direct fraction of 6. AST, ALT was 64 and 42. Her creatinine was, baseline creatinine was around 0.5, 0.6. Sodium was 129. INR was 2.1. The autoimmune markers were strongly positive. The viral markers were negative, and the imaging showed evidence of cirrhosis. She had past episodes of SBP over the last 6 months, which were well treated on OPD basis, and she did not require any ICU admission for that. And she was on waiting list for a cadaveric liver transplant. So this was a patient. So the working diagnosis which our unit had made was autoimmune hepatitis related decompensated cirrhosis of liver with portal hypertension. The MELD sodium score was 28. She had a diuretic intractable ascites, because whenever I used to give her a higher dose of diuretic, she used to develop acute kidney injury, and past episodes of SBP. This is the reason I had shied away from giving any steroids, because I didn't want this patient to land up with a septic hit and compromise her transplant. She was coming fast up on the waiting list. She was on the standard medical therapy, midodrine, and weekly IV albumin course, and I was managing her like this on OPD basis. Somehow she presented to me again in October 2019 with worsening jaundice, however, no hepatic encephalopathy. On evaluation, she had right lower limb pain, and examination showed right lower limb cellulitis. The bilirubin, you can see, shot up to 32 from 11. Her enzymes also kind of went up, the AST predominantly over ALT. GGT also went up to 100. Albumin was 2.6. INR had shot up to 3.4. The WBC count, though here in the normal range, but for her, for this individual, the WBC count was always around 3,000 to 2,800. So this was significant for her with a predominant neutrophilia. And the procalcitonin was 1.2. The creatinine was 1. So her baseline creatinine was 0.6. So this met the criteria for stage 1 AKI. The sodium was 126. So at this point of time, what was the working diagnosis? Again, based on the, I know based on the PASL criteria, we won't call it ACLF because this patient had a DCLD underlying, but based on the EASL and the canonic criteria, this still would qualify for an ACLF. The acute component would be sepsis, and the sepsis, the focus was cellulitis. The chronic component was autoimmune hepatitis related cirrhosis of liver. The acute kidney injury, again, the differentials we had made in our team were pre-renal, either it's a volume responsive type, hepatorenal syndrome, bile cast nephropathy, and because she had evidence of sepsis, so whether it was a sepsis-related acute tubular necrosis. The MELD sodium score was 36, the grade of ACLF was grade 2, and the 2 organ failures, again here, were liver and coagulation. The need for urgent living donor transplant was explained, and luckily the patient's brother came up, and we started the workup for the brother. She was started on supportive treatment, IV antibiotics and IV albumin. This was stage 1 AKI, so obviously IV albumin and treating the cause. So this you can see was the presentation with the septic episode where the bilirubin was 32. After treatment on October 4th, in subsequently couple of days, you can see that the bilirubin shot up from 32 to 39. The INR more or less remained the same from 3.4 to around 3.3. The WBC count luckily started taking a downward trend from 9,000 to 4,000. The procalcitonin, which was around 1.2, normalized to 0.25. The creatinine, which was 1, shot up to 1.9. The sodium more or less remained the same. In the urine routine, we had no very minimal pus cells, bile cast and pigments were present, and the protein was negative. And we had sent a urinary NGAL, which is neutrophil gelatinase associated lipocalin. We usually send it if we have a dilemma between acute tubular necrosis and HRS. This was normal, so this was pushing more and more to a diagnosis of either a hepatorenal with probably a superimposed bile cast nephropathy. Okay, this patient subsequently, in spite of a proper control of sepsis, the leg was looking better, went on to develop altered sensorium and became stuporous on October 6, 2019. We started terlipressin infusion and all the anti-hepatic encephalopathy measures, and she was intubated for her airway protection. So from ACLF grade 2, my patient landed up with ACLF grade 3. So what are the organ failures she had? She had liver failure, she had coagulopathy failure, she had cerebral failure. Though the creatinine did go up as per the ECL criteria, it did not meet the criteria for kidney failure. So it was 1.8 or 1.9. So it should not meet the criteria. So she was having ACLF grade 3 with 3 organ failures at this point of time. So at this point of time, the working diagnosis was worsening ACLF with worsening organ failures and worsening acute kidney injury. So you can see the labs over here that the bilirubin from 32 went on to 39 and subsequently shot up to 42. And here the INR, which was around 3.4, subsequently went on to 3.9. The WBC count continued at a normal range of 4,000 to 5,000. The platelet count was okay. The procalcitonin continued to remain okay. The cultures had grown Klebsiella, for which she was treated with the sensitive antibiotics. The creatinine, however, jumped from 1 to 1.9 to 2.6. So at this point of time on October 7, my patient was having 4 organ failures, and the 4 organ failures were liver failure, it was coagulopathy, it was hepatic encephalopathy grade 3, and she was having a acute kidney injury, meeting the criteria as per the canonic definition. So she was having 4 organ failures, and this was ACLF grade 3. This was on October 7. So at this point of time, I took up the patient for a DPMAS with BS330 and HA332. And subsequently, next day, you can see that the bilirubin had actually come down to 30. The INR was more or less still about 3.5. The most heartening aspect was that the next day we saw her consciousness level had improved. Though she was intubated, she was responsive to commands and localizing everything, whatever we were saying. She was following her commands. Her sodium was 129. So at this point of time, from 4 organ failures, she had 2 organ failures, and the 2 organ failures were liver and coagulopathy. The creatinine had come down to 1.7. So this was the day we had planned up the emergency living donor transplant. She underwent a living donor transplant on October 8 with her brother being the liver donor. We got an adequate GRWR for this patient of approximately 0.85. However, this patient had a very bad post-operative course. She developed a very bad MDR Klebsiella pneumoniae, again requiring polymyxin B. She developed a TAC-related press with seizures and visual impairment. Subsequently, this also improved. She had an ICU stay of 10 days. Again, went to the ward. Again, was shifted to the ICU. Approximate stay in the hospital was approximately as much as 30 to 35 days, and she was discharged on approximately 31st day post-op with normal liver functions on discharge. So this was a very beautiful paper by Dr. Sareen in Nature, showing the importance of ACLF and how we have worsening organ failures. You have a lot of bacterial translocation which happens, which causes the activation of TLR4, and it stimulates the release of inflammatory cytokines like TNF-alpha and interleukin-1 beta. This tissue damage triggers the release of DAMPs, such as damage-associated molecular patterns, and this DAMP subsequently again trigger the innate immunity, which causes a vicious circle. So even if your patient's sepsis is under control, it is this cycle which will cause a very bad inflammatory cytokine storm and will fuel the organ dysfunction in patients of ACLF, though you have treated your patient's sepsis well. This was a study which I had done on patients of ACLF. I had incorporated the partial definition for this study, and I specifically excluded patients who had sepsis. So it was predominantly patients who had ACLF without sepsis over here. And you can see over here, when compared to the garden variety of DCLD, which we find in our OPDs with ascites and MED score of 15-16, patients meeting the partial criteria of ACLF had a proper cytokine storm, which you can see that in terms of their IL-1 and in terms of their IL-8 and TNF-alpha, which is much more higher in ACLF when compared to the CLD criteria. This was one study which I thought is worth mentioning on the role of DPMAS in such situations. So in this study, the authors incorporated 162 patients of chronic severe hepatitis. The mean bilirubin was approximately 8 in this study. 81 patients were randomized to the plasma exchange group, and the 81 patients were randomized to the DPMAS plus plasma exchange group. So they noted that in both the groups, the liver function indices improved, but it was much better in the DPMAS plus plasma exchange, which was also elucidated by the previous speaker. The inflammatory markers came down in both the groups, but the level of inflammatory markers significantly decreased in the combination group. So definitely adding on DPMAS to plasma exchange worked better as per authors in this study. Now, the most important reason why I chose DPMAS in this situation, I wanted to reduce the bilirubin and hepatotoxins in the patient. This led on to the resultant improvement in AKI, bile cache nephropathy. As I told you, if the bilirubin, you can do some strategy to reduce the bilirubin, your bile cache nephropathy is going to improve. And even for hepatorenal syndrome, I did tell you about the terlipressin. So though not a direct effect, but an indirect effect, that if your bilirubin is lower, your responsiveness of HRS to terlipressin improves. So that is another added advantage of doing these strategies in the pre-transplant or the peri-transplant period. Preservation of lungs is very important. So if you ever have a discussion with the transplant team, the first thing they're going to look at is circulatory shock and ARDS, because these are two important things which are going to worry the transplant team for the future transplant. Any patient who's going into ARDS and is having a PO to FiO2 ratio of less than 150, it's a independent poor prognosticator for liver transplant in ACLF. We do know about plasma exchange. There have been several reports of plasma exchange not only causing innocuous side effects like allergic reactions, but triggering TRALI, that is transfusion-related acute lung injury, leading on to ARDS. There are a lot of case reports of this. Obviously, as pointed out, that we need a good amount of volume of 2 to 2.5 liters. So even logistically, it is difficult. But I think for us, the most important worry was with plasma exchange was with TRALI. We have obviously seen this sort of things happening in patients of ALF, wherein we have used a high volume plasma exchange over there. So whether reduction in inflammatory mediators, as has been pointed out in various studies, would result in an improvement of transplant-free survival, I think more RCTs are needed. There is some evidence which has shown that transplant-free survival is improved in intermediate to advanced stage of ACLF patients. But I think more data is needed to convincingly say that this is a therapy wherein we can advocate to patients without the prospect of future transplant. I currently use this as a bridge to transplant currently in my practice. I haven't used it for ALF at least till now in my practice. And I'm interested to think about half dose of plasma exchange along with DPMAS, especially after listening to all the speakers. As of now, I have not combined both, because not only it's about the side effects, but also about the logistic issues like cost in our patients in India. So using both of them also would be very difficult. So as of now, I have not combined it, but that is something which I'm looking forward to. So these are the index cases which I had to present, and most of the other cases revolve around the same index patients. Thank you.
Thank you very much, Dr. Sandeep. Thank you for sharing your cases. It's a pity that case number 1 didn't get transplant, but congratulations for saving case number 2.
Thank you.
So thank you for keeping to time. So now I would like to invite the audience to post any questions in the Q&A, and also the speakers for a discussion and Q&A session. Perhaps I can start the ball rolling. Can I ask Professor Zhao Li, when is a good time to start and when is a time to stop DPMAS?
Okay, thank you. Thank audience for the question. And for the timing about the time start and stop the DPMAS treatment, there are several parts of the answers. The first one, when to begin the DPMAS treatment. For patients not on the liver transplantation waiting list, we need some conditions. First one, the patient should have indication for DPMAS, such as liver failure or liver failure tendency or hyperbilirubinemia. They are all indications. The second one, the patient should have no contraindication for DPMAS. That is, include circulatory failure, active bleeding, DIC, etc. The third one, the causes and or inducement of the liver failure should be controlled very well, such as HBV, all kinds of infection, etc. So when all the three conditions above are present, we should begin sequential ALSS, include DPMAS as soon as possible. And this is my opinion. And another part of patients, that is the patients on the LT waiting list, once the patient has indication and no contraindication, we should begin ALSS, including DPMAS, as soon as possible to give them more time waiting for the liver donor. And that is to say, even the cause or the inducement is not controlled that well or very well, we should consider ALSS, include DPMAS, as soon as possible. Otherwise, the patient may have no chance to wait for the liver donor. And for the when to stop the DPMAS treatment, when biomarkers, and that is PTA, prothrombin activity, and total bilirubin get stable and better at that level, that is increasing PTA and decreasing bilirubin, as well as the patient's symptoms get improved, at this time we could stop the DPMAS treatment. And second condition is when the patient's condition gets worse, that is the total bilirubin rebound to a new highest level, much higher than any before level, and complications aggravated or onset of new complications such as UGIB, infection, hepatorenal syndrome, etc. And after, if patients get worse, like above, after sequential ALSS, including DPMAS, of course, we should assess the patient again. And if the liver, if we consider the liver regeneration is very poor, and generally speaking, the total prognosis is very poor, it means the patient needs liver transplantation to survive. So if the patient is waiting for liver transplantation, as I have said before, we should continue the ALSS. Otherwise, if the patient is not waiting, if the patient and and their relatives chose to not conduct liver transplantation, we should stop the ALSS because the patient could not survive without LT. But for the patients waiting for LT, we should do our best. We should continue ALSS until the liver transplantation. That is for this question. Thank you.
Thank you. Professor Ranista, do you have anything to add? Professor Ranista?
Sorry. For my institutions, we have some problem regarding the organ shortage and regarding the government reimbursement. Then we can select, let I share the screen. I try to select the time of start, because if you start too early, it's gonna be problem with economic and your deal regarding the money. If you start too late, is not so good of the patients.
It's true.
I try to select the case with the window like this. For example, try to start very early, and if that case has some problem regarding the financials, I start earlier with the CRRT before and after talk with transplantation team with the availability of DPMAS and so on. Then we start liver support concurrently with CRRT. Then I always use some like this study. If I saw the patient did not in acute liver failure, if she is not fit with transplantation, I did not do anything with liver support except the case with acetaminophen overdose. In ACLF, I always shoot when AARC score higher than 2 or 3 and follow. If no providing of liver transplant and secondary infection like sepsis or multi-organ dysfunction occur, I stop the treatment. Thank you.
Thank you. Thank you. Where's my slide? Can I ask Dr. Sandeep, how do you evaluate patients before, during, and after DPMAS in terms of signs, symptoms, and labs?
Yeah, so I think as I mentioned about the choosing, I think we are in a very good time. We have very good, excellent scores now, like the ARC score or the CLIPSI ACLF score. So right away, if my patient's CLIPSI ACLF score is anything more than 64, it indicates more of futility analysis, and I wouldn't take this patient up for either DPMAS or anything of that sort. If the inotropic support is rapidly worsening, escalating, if the patient has ARDS, again, this wouldn't meet the criteria for DPMAS in my clinical practice as of now, at least. During the DPMAS procedure, I have been lucky. I have not seen any major complications. I think one patient had very bad chills, and he was complaining of, for which we just got sorted off with some antihistaminics. But none of the patient had any adverse effects with DPMAS vis-a-vis when I compare it with plasma exchange, which was most frequently I used to have patients with some fever, very bad allergic reactions. And as I told you, I have encountered a couple of patients with very bad ARDS because of the trolley. So during the during the episode of DPMAS, I don't think that there's anything specific rather than just looking for the routine hemodynamic picture. And in the post DPMAS, I think the most important point is how your bilirubin rebounds, because definitely the bilirubin does come down with DPMAS, but the steepness with which it goes up will dictate a lot about how the patient is going to behave. So in my first patient, which I told that the bilirubin actually started going up right from the second day of doing DPMAS, actually did hint that this patient's underlying liver disease was quite significant and quite bad. Again, giving us the importance of doing a curative therapy with transplant.
Questions. How do you choose anticoagulant agent? Dr. Sandeep, over to you. How do you choose anticoagulant agent?
Yeah, I think that's a very interesting question. So most of the times we do anticoagulant-free dialysis, and if at all we have to use it, they use citrate anticoagulation with the filters when we use a routine dialysis when we want to use the DPMAS. So most of patients are coagulopathic, their platelets are low, their INRs are pretty high. So only to prevent clotting of the circuit, I think the nephrologist, the dialysis team uses some amount of citrate. But other than that, I don't think we use any systemic anticoagulation for these patients.
All right. What about Professor Lee? How do you choose anticoagulant?
We use the heparin 2 as an anticoagulation agent in my center, and we according to the patient's PTA number and the platelet number and any tendency of blooding, and the body weight and some other values to determine the personal dose of the heparin for each patient. And more important, after the initial dose, we must monitor, we must look at the pressure in the machine. Once the TMP begin to increase, we must judge that that's a normal increase or abnormal increase. Once an abnormal increase happened, we must give another dose of heparin at once.
Okay.
Thank you.
Do you have anything to add, Professor Anista?
Okay, for my institution, because most of our case has some coagulopathy, then we did not use any anticoagulant, and also for citrate is not so good if the liver function quite bad, like in acute liver failure. And in our institution, we almost all use the no anticoagulation, but we monitor TMP also, and in every case, we rinse the filters before start treatment with saline concurrently with heparin. And after that, we flush it out and perform the treatment. Thank you.
Okay, thank you. There's another question. What's the difference between MARA? I suppose it's MAS and DPMAS. Who want to take this first? Yeah, any difference between MAS and DPMAS?
Yeah, I can explain some. For MAS system, they use the system that combine liver and kidney support. For liver support, they use MAS filters, which is you can remove the toxin in albumin of the patient via these filters and go entry into the albumin system of extracorporeal system. After that, the toxin and albumin in the extracorporeal circuit go through the adsorbent to adsorbent. Can I show my slide if you want? Maybe easier.
Okay.
I'm sorry. In short, the MAS system use the special system treatment, including renal and liver system, and they use a lot of albumin. For example, 20% albumin for 12 bottles, and the treatment not only for liver but for kidney. The real problem of MAS is very expensive, and the main problem is the extracorporeal circuit clotting in the MAS filters. For DPMAS, in my opinion, and in my experience, I did not saw the clot anymore. But the real problem is that they did not perform the renal support as good as have done. Anyway, we can use concurrently treatment with CRRT and DPMAS instead of MAS.
Okay, thank you. In the interest of time, maybe perhaps we just go around to our esteemed speakers to give us a summary of your talk in 1 or 2 sentences. Can I start with Professor Lee, just to summarize?
Thank you. I think the DPMAS is a very useful method for us to treat the patients with ACLF. And sometimes we need a hybrid method, hybrid mode, include DPMAS, such as DPMAS+PE. And we also, in my center, we also do some other hybrid method. And we can use all the ALSS mode, including DPMAS, to give the patients better treatment and get them a higher survival rate. Thank you.
Thank you. Thank you. Professor Ranista?
Okay, for me, DPMAS is very good ALSS, but in case with other problem like hepatic encephalopathies, renal dysfunctions, or coagulopathy, maybe we perform combination between DPMAS, plasma exchange, and CRT.
Okay, thank you. Dr. Sandeep?
Yeah, I think from my point of view, I think the take-home point should be that we need to make ourselves very clear that the liver transplant is going to be the most important treatment for your patient of ACLF. And the role of these therapies are just as a bridge, wherein if, as I presented, that if your patient is having worsening organ failures, worsening kidney injuries, increasing bilirubin, worsening encephalopathy, these are the patients where we are very skeptic about taking them for a living donor transplant. So for such patients, you can buy time by doing the DPMAS so that your end goal can be doing a transplant and giving a long-term cure for the patient. So it should not be seen as a substitute to transplant, but it should be seen as a bridge to transplant, at least based on the data currently what we have.
Okay, thank you. So I would like to thank everyone, to our esteemed speakers, to the audience who asked questions and participations. I think we had a very useful, informative webinar, and I would like to thank Jeffron for organizing this. Last but not least, keep safe, stay well, everyone, and good night.
Thank you. Good night.
Thank you.
Good night, everyone.
Good night.
Oh.